You're listening to Into the Loop, the podcast that unpacks the twists, turns, and repeating cycles of obsessive compulsive disorder. Here, we have amazing hosts that are going to introduce and dive together into the real side of OCD and for beyond the stereotypes. From the intrusive thoughts to compulsions, from treatment myths to breakthroughs, our goal is simple: to help you feel seen, supported, and empowered as we explore the patterns of the mind together. Let's begin.
How's it going, everyone? Welcome to today's episode of Into the Loop OCD podcast. I'm your host, Brandon, and today I'll be talking about the symptoms of obsessive compulsive disorder. A lot of people joke about being so OCD because they like their room clean and, they like their notes colored a certain way, but the real disorder is nothing like that, right? OCD isn't about having quirks or personality quirks. It's an anxiety disorder that traps, a lot of people in a cycle of unwanted thoughts and repetitive behaviors. OCD starts with something called obsessions. These are intrusive thoughts, images, or urges that pop into someone's mind without permission. They're usually disturbing or completely out of character. For example, someone might suddenly fear contamination, imagine harming someone they care about, question their morality or their faith, or feel overwhelmed by the need for perfect symmetry, right? The key part is that these thoughts are not wanted. They're actually scary and kind of disgust to people who have them, right? Then come the compulsions, right? This is another symptoms of OCD. Compulsions are behaviors or mental rituals that people do to try to reduce anxiety that are caused by these obsessions, right? So let's say if someone were to fear contamination, they might want to wash their hands until the skin is completely raw, right? You kind of see that a lot. If someone has intrusive thoughts about harm, they might check locks or appliances over and over to make sure that nothing bad has happened. Um, some compulsions are physical, like cleaning, checking, or arranging, and others are mental, like counting, like praying, repeating phrases, or constantly seeking reassurance. Yeah. The problem is that relief someone gets from a compulsion is pretty much temporary. Yeah. The intrusive thought eventually comes back and the cycle repeats. Over time, this can take up hours, a day, interfere with work or school, and cause a huge amount of stress and shame. Right? It's important to say that people with OCD that usually know their thoughts don't make logical sense. Right? It's not delusional. It's just anxiety. Their brain just won't let it go. Right? They won't let this fear go, and the compulsions feel like it's the only way that they can get through what's currently happening right through the moment. Some common areas where OCD shows up include contamination fears, checking behaviors, fears of causing harm, perfection and symmetry, religious or moral worries, and intrusive taboo thoughts that people would never act on, right? And OCD can lead to avoidance of doorknobs, right? Crowded places, sharp objects, and anything that triggers this obsession. Um, OCD symptoms usually get worse under stress or major life changes, and they can seriously impact a person's quality of life, right? And that's really what it comes down to, right? The symptoms of it, right? And that's basically, uh, like I mentioned earlier, the intrusive thoughts and the compulsions. Yeah. Uh, Again, these are just mental rituals that people with OCD have, right? And it's something that they know that they're not supposed to be doing, or that they know themselves that it's uh, delusional. But again, this is just a part of OCD and its behavior. Uh, and that's all from me. Thank you. We'll move on to the next segment of our podcast.
Hi, everyone, and welcome back to Into the Loop. I'm your host, Lillian Penchak, and I'll be talking about the diagnostic criteria in diagnosing obsessive compulsive disorder. I wanted to talk about what clinicians look for when diagnosing OCD and what defines obsessions and compulsions, and how these patterns can actually affect the daily life of an individual who is diagnosed with this disorder. As Brandon mentioned before on symptoms, I am going to repeat a few things that he mentioned about obsessions and compulsions. So, how do clinicians actually diagnose obsessive compulsive disorder? Now, there's a huge gap between what OCD really is and what most people think it is. So, today we're turning straight to the DSM 5 TR. This is the diagnostic manual used by clinicians in the United States, and breaking down what they actually look for in a clear and human way. So, what do clinicians look for? So, when someone walks into a therapist office and says, I think I might have OCD, clinicians don't jump to conclusions and they look for very specific patterns. And usually, those patterns are straight from the DSM 5. Clinicians will usually begin to look for obsessions, compulsions, or more often both. And OCD is not about liking things tidy, color coded, or aesthetically pleasing. It's more than that. It is about intrusive, unwanted mental experiences and the rituals a person feels driven to perform to quiet them. So, Brandon had mentioned symptoms earlier. So, yes, clinicians look for presence of obsessions, compulsions, or both. Now, for a clinician to determine whether a person experience an obsession, usually there are intrusive mental events. These are recurrent, unwanted, intrusive thoughts, images, or urges. They usually cause noticeable anxiety or distress on the individual, and the person tries to ignore or neutralize, or usually try to suppress them, often resulting in through a compulsion. A common example for what this might look like for an individual experiencing these thoughts, and it could be like, what if I hit someone with my car and I didn't notice? I have a fear of germs, contamination, or illness because I'm afraid of getting sick. I'm afraid of those around me getting sick. They could also experience intrusive taboo thoughts that can be sexual, religious, sometimes violent. And another, which is most commonly seen, which is that perfectionistic or symmetry based thought. So, compulsions, these are the behaviors that or mental rituals that these person might perform in order to relieve or suppress the obsession. And these are repetitive actions that the person may feel driven to perform. A lot of this is usually aimed at reducing anxiety or preventing a feared event that the individual might be experiencing, that image in their head or thought. And a lot of the times that this is not something that's realistically connected to what they're trying to prevent. That is obviously clearly excessive on their part. So examples of this are excessive hand washing or cleaning. Some clinicians may see signs that this person obviously may have dry skin on top of their hands due to the excessive cleaning. Maybe they wear gloves often to not touch anyone. Rechecking is another example of compulsion. This is rechecking locks, maybe even unlocking a few times, unplugging appliances, checking for mistakes. Sometimes a compulsion can also include counting, tapping, repeating phrases, mental rituals that include praying or reviewing memories. Now, a second clue, as I would say, how what a clinician may look for in diagnosing is the time consumption and the functional interference. What is not functioning in the person's life, and how time consuming this is. These actions, these behaviors are present in the person's life. So, Brandon mentioned time consuming. Like these things take more than an hour per day. So, um, it would have to be causing a significant impairment, as I mentioned earlier, in this person's life. This can include their social functioning, relationships with their loved ones, their friends, their peers, their coworkers. It can affect school or work. Maybe it can impair their schoolwork, meaning to perform well in their on their grades or courses. Maybe to perform well in their duties that can cause job loss. I mentioned before relationships and their daily routines in general. So clinicians may ask an individual, how much time do these rituals take each day? Another question, do these thoughts interrupt your ability to work or sleep? And another question would be, have you avoided people or places because of them? Now, the reason why clinicians would ask these questions is usually due to what level of insight their clients may have of their behaviors and conditions. So, clinicians will evaluate how much the person would recognize their thoughts and behaviors as irrational. So, an example of this if a person has good insight, they normally will naturally express that. I know it doesn't make any sense, but I feel like I have to do it. Another example is poor insight, which is the belief that um, their fears might be true. Lastly, is uh, the absence of insight, which is delusional. The person is convinced that the intrusive thoughts reflect reality. So, insight does not rule out OCD, it just simply helps out in the treatment planning. So, another way that clinicians might rule out other disorders in diagnosing their clients with OCD is usually by measuring what's happening in their lives. So, they can usually perform clinical interviews, and these usually consist of a structured or a semi structured approach. Another is the YBOCS, which is the Yale Brown Obsessive Compulsive Scale. This is a very common gold standard, usually due to the severity of the client. Um, a, Another is a OCIR, which is the Obsessive Compulsive Inventory. And lastly is the psychosocial history, alongside with the functional assessment of how much it is actually impacting the client's life. So clinicians want to rule out other disorders. Uh, so they'll have, as I mentioned before, the two signifiers, which is a level of insight, and tick related OCD, which is normally due to if the client may have prior disorders like Tourette's. That is a tick related OCD. I'm sorry, a tick related disorder. So OCD is not due to substances, medical conditions, or other disorders. So symptoms cannot be better explained by disorders that are similar, like generalized anxiety disorder, which is constant worry versus intrusive thoughts; body dysmorphic disorder, which is preoccupation with appearances; eating disorders, which are rituals around food and weight; hoarding disorders; psychotic disorders; and substance use. So, this step is very crucial in preventing misdiagnosis in the individual's diagnoses. Avoidance is a very key sign of OCD. So, it's not only rituals. A good example of this may be avoiding knives because of intrusive harm thoughts, avoiding touching doorknobs due to contamination fear, avoiding relationships due to fear or infidelity thoughts, avoiding driving due to fear of accidental harm. Avoidance supports the diagnosis when paired with obsessions and compulsions. So, to summarize, clinicians diagnose OCD when one, obsessions, compulsions, or both are present; two, they take 1 hour per day or cause major distress or impairment; three, the person tries to suppress or neutralize the intrusive thoughts; four, rituals are excessive, repetitive, and anxiety driven; five, symptoms aren't caused by another disorder; and six, insight levels are assessed; and seven, which the symptoms have to fit a recognizable OCD pattern. So let's look at a case study regarding a 29-year-old female. Her name is Elena Morales. She is a Hispanic American. Her occupation is she's an elementary school teacher, and her marital status is that she's engaged to her partner. Now, Elena sought therapy after experiencing constant anxiety and exhaustion caused by repetitive and checking behaviors. So she reported spending up to 2 hours each morning ensuring that the household appliances, like the stove, hair straightener, and iron, were unplugged. She often left her apartment only to turn back multiple times to make sure. These behaviors caused her to arrive too late to work, increasing her stress and a sense of guilt. Now, Elena described her intrusive thoughts of her apartment catching fire or her fiancé being hurt because of her carelessness. And to neutralize these thoughts, she developed a mental ritual such as silently repeating phrases or counting to 10 before leaving a room. Now, she acknowledged the irrationality of these actions, which gave her good insight that she has She is acknowledging that she is performing these behaviors, but she felt powerless to stop them. So let's look at the history and background of Elena. Elena grew up in a close knit family that valued cleanliness, order, and responsibility. Her mother frequently reminded her that a good home reflects a good person. As a child, Elena developed a fear of disappointing others and often felt responsible for preventing problems. During her college years, the behaviors intensified after a small kitchen fire occurred in her dorm. Since then, she had linked safety with repetitive checking. She has no history of substance use or major medical conditions, but reported occasional panic attacks when unable to complete her rituals. Now let's get into her clinical observations and assessment. During the intake session, Elena appeared anxious but cooperative. She frequently apologized for perceived mistakes in her storytelling. Her thought process was logical, but content revealed intrusive fears of harm and exaggerated responsibility. And Elena completed the Yale Brown Obsessive Compulsive Scale, which is the YBOCS, scoring 28, indicating severe OCD symptoms. Now, no psychotic features or major depressive episodes were observed, though the secondary anxiety and fatigue were evident. According to the DSM 5 TR criteria, Elena meets the diagnostic threshold for obsessive compulsive disorder. This is characterized by recurrent intrusive thoughts, which is her obsessions, the compulsions aimed at reducing anxiety, which is the checking and counting, recognition that behaviors are excessive, and significant distress and impairment in daily functioning. Now, there are a few approaches in how we can determine a treatment plan for Elena. And one of them is cognitive behavioral therapy, which is CBT with exposure and response prevention, ERP. And this is a gradual exposure to leaving home without checking appliances while resisting the urge to return them. The second is a psychoeducation, teaching Elena about the OCD cycle and how compulsions reinforce anxiety. The next is relaxation and mindfulness techniques, deep breathing and grounding exercises. This is to manage anxiety during exposure tasks. The next is family involvement, educating her fiance about OCD to reduce reassurance seeking behaviors. And lastly, possible medications, a referral to a psychiatrist for an evaluation of SSRIs to help reduce obsession or obsessive thoughts in Elena's condition. Our episode will briefly go through the treatment plan options for OCD in a later segment, but let's continue on Elena's case study. So let's talk about Elena's prognosis and discussion. Elena Strong's insight and motivation for treatment indicate a good prognosis. However, her perfectionistic personality traits and cultural emphasis on responsibility may change progress. With consistent CBT and support, she is expected to experience a reduction in compulsive behaviors and improved functioning. This case demonstrates how OCD can intertwine with cultural values, stress, and perfectionism, highlighting the importance of empathy, cultural awareness, and evidence based interventions in treatment. This concludes this segment on the diagnostic criteria for OCD, and moving on to the next segment with your next host.
Hello, everyone. Welcome to the podcast. My name is Adrian Acosta, and I'm gonna be talking about the prevalence of OCD. So let's start close to home now. According to the National Institute of Mental Health, about 1.2% of adults in the United States they experience OCD in a given year. That's roughly around 3 million adults, and if we look at lifetime numbers, it jumps to around 2.3%. So roughly 140 people will meet the criteria for OCD at some point in their lives. So to put it simply, OCD is not a rare psychiatric disorder. It's actually one of the more common ones, comparable in prevalence to conditions like bipolar disorder or schizophrenia. But it's often misunderstood or minimized as just being neat or just liking things organized, which is very far from the reality, you know? So when we talk about the global prevalence, the numbers are very striking. No, the WHO, the World Health Organization, they estimate that OCD affects about 2% of the world's population. If we do the numbers, that's roughly around 160 million people. A lot of recent research from the BMC medicine, sorry, in 2025, they found that a combined lifetime prevalence of 4.1% across 10 countries, with a 12-month rate of about 3%. There's been other meta-analysis suggesting slightly lower global averages, closer to 1.3%. It's pretty much depending on how the studies were done. So when you take all that together, it's safe to say that OCD consistently shows up across every cultural, language, and country study. It's pretty much a global mental health issue, not just a Western phenomenon, as some people like to put it. No? What about age of onset? One thing that really stands out about OCD is when it begins. About half of the people with OCD, they show symptoms before the age of 19. This is according to the Journal of Clinical Psychiatry. And many studies show that over 80% of cases begin by early adulthood. In children, the average age of onset is around 10 years old. Boys are more likely to develop OCD at a younger age than girls. The early start often means that people live with symptoms for years before getting the right diagnosis or the right treatment. So with the numbers that we see in the data may actually underestimate how many people are truly struggling. When it comes to genders, overall OCD affects men and women at almost equal rates, but there are some interesting patterns. Let's put it like that, no? Boys tend to show symptoms early in life, while women are slightly more likely to be diagnosed in adulthood. In fact, US data from the NIMH found that past year prevalence of 1.8% among women compared to 0.5% among men. And some meta-analyses that have been done show that women may be about 1.5 to 1.6 times more likely to experience OCD during the lifetime. So while the lifetime totals are close, the timing and the expression of OCD can look a little bit different between the genders. So what about the trends over time? No? That's a question that a lot of people ask. Is OCD becoming more common? And if we want to give it a short answer, not really. A lot of research shows that the true prevalence of OCD has remained pretty stable over the past few decades. But what has really changed is our awareness of the disorder. No, we're seeing higher diagnosis rates because more people recognize the symptoms. Screening tools have improved, and talking about mental health is finally more accepted in society. No, so it's not that more people suddenly have OCD, quotation marks, is that more people are finally being seen and treated. So final thoughts on this. 1 in 40 adults in the US, 3% of people worldwide, half of the cases begin in childhood or adolescence. It's very equal between men and women. And what the numbers haven't exploded over time, our awareness thankfully has, put it that way. If anything, that means that people are starting to recognize that OCD isn't a personality quirk. It's real, treatable condition that deserves understanding and support. I'm gonna pass it over.
Hey everyone, my name's Genesis. Thanks for taking the time to keep on listening, and let's just dive into my part of today's podcast. We're diving into a topic of what a lot of people think they understand, but there's way too more than what we see in movies or on social media such as TikTok. We're talking about obsessive compulsive disorder. Let's keep diving in a little bit more. So, you've probably heard people say things like, I'm so OCD about my room, or I have to color code everything, I must have OCD. But the truth is OCD is way more complex than being neat or just organized or having rituals. So today we're tackling two big questions. What actually causes OCD, and why is it important that we study it? So let's get into it. What causes OCD? The first thing you need to know is that there isn't one single cause. OCD is like catching a cold where you can point to one specific thing. Instead, it's more like a mix of different factors working together, kind of like pieces of a puzzle. Research shows that OCD is linked to how certain brain circuits communicate, especially areas involved in decision making, emotions, and habits. If these circuits are overactive or not regulating correctly, it can make a person feel like something is wrong, even when everything is fine. It's kind of like having a smoke alarm that keeps going off even when there is no fire. Another major factor is genetics. OCD can run in families, not in a guaranteed way, but in a way that increases risk. It's like inheriting a sensitivity rather than the disorder itself. If a parent or sibling has OCD, you're more likely to develop it, but it's not a sure thing. Stress doesn't cause OCD by itself, but it can trigger symptoms or even make them worse. Think like really big life changes, academic pressures, relationship issues, problems at home, financial pressures, or even things that like shake someone's routine and emotional balance. For people already vulnerable, stress can just be the spark that brings symptoms into the spotlight. In rare cases, usually in children, OCD symptoms can appear suddenly after certain infections. Um, this shows that OCD isn't only psychological, but there are also physical and biological components. And then there's the behavior side. If someone feels anxious and then performs a compulsion, like checking, washing, or repeating something, it temporarily relieves anxiety. The brain learns to depend on that behavior. Over time, this cycle becomes automatic and really difficult to break. So, why is it important to study OCD? Now that we've covered what causes OCD, um, let's talk about why studying it actually matters. Because understanding why something happens is only half of the story. The other half is why do we need this knowledge in the real world? So many people live with OCD for years before getting diagnosed. It's constantly overlooked. Um, they might feel embarrassed, confused, or think their symptoms aren't serious enough. By studying OCD, researchers and mental health professionals can create better tools for early detection so people don't have to struggle in silence. There are effective treatments for OCD, like therapy, medication, but not every treatment works perfectly for everyone. Studying OCD helps us understand which approaches work best, and it leads to new treatment ideas. The more we learn about the brain circuits and behaviors involved in OCD, the more precise and personalized these treatments can become. And let's be honest, OCD is one of the most misunderstood mental health disorders out there. People throw this term around casually, which minimizes the very real challenges people with OCD face. Studying OCD and spreading accurate information helps correct these stereotypes. It encourages empathy, awareness, support. OCD can affect daily life in a major way. Intrusive thoughts, rituals, anxiety can take up hours of someone's day and make simple tasks feel super overwhelming. By studying OCD, we help people regain control of their time, their routines, and their mental well being. And finally, studying OCD doesn't just help people with OCD, it helps everyone. Research on OCD gives scientists insight into how the brain handles fear, habits, rewards, and decision making. These discoveries can improve our understanding of our mental health conditions too. So to wrap everything up, OCD is just a complex disorder caused by a mix of brain wiring, genetics, stress, biology, and learned behaviors. And studying OCD is incredibly important because it leads to earlier diagnosis, better treatments, reduced stigma, and overall better lives for these people who experience it every day. Thanks for tuning into my part of today's episode, and I hope we gave you a great insight into why we should keep on studying.
My name is Tabitha de Renoncourt. I want to welcome you to Into the Loop podcast. We talk about symptom, we talk about diagnostic. Now we're going to talk about treatments. First, let's talk about behavioral treatment, also called exposure and response prevention. It is the most effective treatment for OCD. It is when you expose the person who is diagnosed with OCD repeatedly to the stimuli that provoke his or her obsessions. I'm going to explain. For example, if the obsessions is about contaminations, germs, you may bring that person to a public toilet and make that person repeatedly touch the toilet. By doing so, that can help reduce her or his anxiety. Now we're gonna also talk about the medications. According to Fireberg, OCD seems to respond best to medications that affect the serotonin system. For instance, clomipramine and fluoxetine. Those medications reduce the intensity of the symptom 40 to 60%, which is a great percentage which can help the person cope with OCD. Also, we have some advantage and disadvantage for the medications. For example, people who only taking medication may depend on that medication because discontinue of that medication may cause relapse. This is why sometimes it is better for people to search alternative form of behavior therapy which is long lasting benefit.
I wanted to add a little bit on to Tabitha's segment on treatment. So, yes, medication and therapy are incredibly effective when it comes to long term treatment for OCD. And these ERPs and SSRIs medication can lower the intensity of obsessions, which makes ERP therapy easier to engage with. And ERP teaches the brain how to reduce those compulsions over time. So think of it like this: medication turns down the volume, and ERP teaches your brain not to respond to the noise. For some people, medication alone helps, for others, therapy alone is enough. But many find that the combination gives them the strongest and most stable progress. And this brings us to the end of today's episode of Into the Loop. OCD is a complex and often misunderstood condition, but understanding the DSM 5 criteria, recognizing what clinicians look for, and knowing the treatment options brings us one step closer to breaking the stigma and opening real conversations about mental health. If today's episode helped you learn something new, feel seen, or feel less alone, make sure to follow the show so you never miss an episode, and share with us with something you might benefit, and leave us a review. Thank you for listening, thank you for learning, and thank you for stepping into the loop.